All right. Thank you everyone for coming today to our last actual event for National Public Health Week. I hope y'all have enjoyed some of the events you've been able to attend either virtually or in person this week. To introduce our speaker, Heather Sue Rosen, they, is a postdoctoral scholar at the New England Complex Systems Institute through their World Health Network initiative. She is a medical sociologist and quantitative methodologist specializing in health beliefs, health behavior, and computational approaches to social network analysis. Her research has examined patient experiences in healthcare, the connection between depression and disability, and the expression of beliefs about disability, COVID-19 risk, and prevention online. She is currently involved in research projects focused on excess mortality, viral concentrations of COVID-19 in wastewater, and the COVID-19 pandemic's impact on the prevalence of chronic illness among adults living in the United States. Thank you, Dr. Rosen, for joining us today, and I'm going to pass it over to you to do your presentation.
Thanks so much for having me. There is a link in the chat for anyone that wants to follow along on their own, but I'm also going to go ahead and just share my screen as well. Right. So today I'm going to be talking about disability and emergency preparedness. And so I'll start just by defining disability, which seems a little bit silly, but it's not something that's necessarily intuitive. So a disability is any condition that impacts a person's participation in daily life activities. This can look like a physical disability, something that requires medical equipment, or even something that doesn't, but limits your ability to move around. It can also be learning disabilities like autism, ADHD, dyslexia. It could also be chronic illness, or it can be things like depression, anxiety, schizophrenia, your whole list of mental illness diagnoses. So it's pretty broad. Now, disability in public health, even though that is the definition that I just gave you, is from our Centers for Disease Control and Prevention, the CDC, and it's based off of the World Health Organization's definition of disability. In practice and in research, what usually ends up happening is that disability ends up being conceptualized as either an outcome to be prevented or as a means of identifying what we like to call vulnerable populations. This is really important because it directly relates to how disability is handled with emergency preparedness during disasters, and also some of the impacts on disabled people during those disasters. So emergency preparedness is simply preparing for a disaster. And emergency preparedness often focuses on disasters that are brought on by weather events. So things like avalanches, floodings, droughts, earthquakes, hurricanes, landslides, tsunamis, volcanoes, wildfires, things like that. Disasters can also include hazards brought on by things other than weather, though, and this is really important and something that we've seen, obviously, during the COVID-19 pandemic. So it can include things like disease outbreaks, epidemics, pandemics, also things like chemical exposures, and then things like we've seen in a lot of current events in the world, so food supply shortages and warfare. So the problem with the traditional public health approach to disability for emergency preparedness is that disability can render the standard resources that are outlined for handling the emergencies either unavailable, inaccessible, more difficult to use, or require them to only be used with the assistance of others. So it's not something that you can necessarily do on your own. A really good example of this is if there's a fire in the building and there's an elevator, you're not supposed to use the elevator. But say you have a physical disability that limits your ability to use the stairs, whether you use medical equipment or not. Some people just can't do stairs. In that case, say you're stuck on the third floor of the building, the fire department has to come get you, and they have these special chair things, and they have to actually like carry you out of the building. If you don't have one of those, you have to hope that somebody grabs you and carries you out of the building. So this can be really, really limiting, scary, and lead to some really negative consequences, like being left behind. Another problem is that during an emergency, a lot of the focus is going to shift to preventing disability. So this idea that disability is an outcome to be prevented, and specifically preventing it in non-disabled populations. So a lot of the times the focus is not, oh my goodness, there are disabled people here. How do I make sure that they don't get worse? It's, oh my goodness, this person has a broken leg. They were already non-disabled. How do I make sure that they don't end up having to use a wheelchair for the rest of their life? This means that disabled people are often the last to be rescued, and it makes them a lot more likely to experience negative consequences like exacerbation or new disabilities from the disaster. Now, disease outbreaks, epidemics, and pandemics are supposed to be the exception here. So during emergencies related to infectious disease, the focus does technically shift to protecting vulnerable populations, so protecting disabled people. And this seems like a really good idea. We should protect the vulnerable. That's what I was just pointing out was a problem with, really like weather-related disasters in particular. The problem is there's a little bit of a gap between the expectation and the reality of how this is handled. So the expectation is that tailoring protections to individual needs will help us protect the most vulnerable while also allowing the least vulnerable to take the fewest actions possible. The reality of the situation, something that we've especially seen during COVID-19, has shown us that protections for the entire population need to be tailored to the needs of the most vulnerable because risk is shared and it can't necessarily be isolated. So what this means is if you have your least vulnerable populations, non-disabled people, taking minimal actions, sometimes the actions of the vulnerable populations or people closest to them won't be effective because there's some sort of cross exposure. So a good example of this is, say you have the grocery store, and COVID-19 is spread by airborne particles. Well, the expectation is that, okay, well, vulnerable people, people who are around them at home can just go to the grocery store, maybe they can wear a mask, and nobody else in the grocery store has to wear a mask. The problem is masks are not perfect protection, so there could still be some exposure there. The reason I use the example of masks in the grocery store is because of this other reality that we have. So working with the same expectation. The other reality here is that vulnerable populations may be unable to use protections as effectively or at all which means that they're going to rely on other people's actions for protection, right? So thinking back to my earlier slide where these regular resources may be ineffective, inaccessible, or more difficult to use. So one example is if you have a breathing tube that's like in your neck, you can't wear a mask, or if you wear a mask, it's not really going to matter because the air is entering your body through your neck. Well, if you decide to go to the grocery store, you can't wear a mask. And if nobody else is wearing a mask, there's still going to be exposure to this airborne virus. So there's been a big push, really not even since the pandemic started, but going all the way back to, at least in the United States, really Hurricane Katrina. So back to like 2005. And then following that, the H1N1 flu outbreak in 2009. Both of these showed us that we really need a disability-centered approach to emergency preparedness, which means centering the needs of the most vulnerable in society. Research has found that promoting both self-efficacy, so not just the ability to do things on your own, but really the confidence and like wherewithal to feel like you can do these things by yourself, but also collective action. So the community coming together and helping each other when there are these things that can't be done individually. Both of these things together is the best way to accomplish this disability-centered approach to emergency preparedness. Now, this research goes, again, like I said, back to 2005, possibly even earlier, but the bulk of it coming since Hurricane Katrina. We can see that in practice, we haven't had a whole ton of change, right? COVID-19 is an excellent example of how we haven't really seen that change. There's been a lot of focus on just the self-efficacy piece, right? So you protect yourself, and if you feel like protecting others, then that's great, you do that. So, and also collective action in the sense of like smaller communities like your household. If you live with somebody vulnerable, then maybe you'll take heightened precautions. But if you don't live with someone vulnerable, then it maybe shouldn't matter, right? And both of these things are counter to this disability-centered approach that research has found is important and that public health has technically been promoting for almost like 20 years. What I found in my research is one of the most important things to fostering both self-efficacy and collective action is effective communication from experts in public health. And when I say expert, I don't necessarily mean you have a million fancy degrees and a million titles. I mean, there are plenty of public health workers on the ground who maybe don't have much education, but they do work in public health and they're there every single day trying to make these plans. Anybody that you would consider someone of authority can be considered an expert. So even someone like the President of the United States, your representatives, your senators, and things like that. If these people are not giving you the information that you need, or they're presenting information in a way that is confusing or conflicting, that tends to lead people to sort of, I guess, just shut down or turn away. It becomes extremely overwhelming, or it can be perceived as useless. So one of the things that at least I've found that we can learn from COVID-19 is that if we can all get experts on the same page and remember that we've been promoting this disability-centered approach, then that can be something that's really, really helpful for the continued pandemic, for all of the warfare that's going on in the world, for addressing the famine that's going on in the world, and for anything that's going to happen in the future. We also know with climate change that this is just going to be increasingly important, both because climate change puts us at risk for new pandemics, puts us at risk for further famine, but also because it puts us at risk for more and more severe weather-related disasters. Luckily, there's been a lot of effort in this area, at least when it comes to the disease aspects. We do have people who are learning and trying to make changes based on what has happened during COVID-19. The areas that we really could improve upon is everything else. A really good example is if you look at what is going on in Gaza right now, we can see that there have not been these lessons learned about centering the most vulnerable, right? We've seen a lot of devastating outcomes that continue to happen even as recently as yesterday and today. Another thing that we can see is we're going to be coming into hurricane season. Our last few hurricane seasons have been a lot more severe than previously. And we've seen that lack of adequate planning has led to some pretty devastating outcomes. So one of the things that I would encourage, especially if you are planning to go into either public health or emergency preparedness, is to really think about not just how you can do these things, but how can you communicate with your peers, with your colleagues, to all get on the same page. And one of the best ways that I found is to explain when we're protecting the most vulnerable, it's not an them versus us thing. Those protections will ultimately make everybody safer. They're not just going to protect the most vulnerable. So they are important, and they are important for everybody. And that's something that does seem to resound with a lot of the population. The other thing to remember is that with these increased threats, the risk of becoming part of the vulnerable population yourself, unfortunately, is a lot higher. So also remembering and communicating to peers, even if we're not part of those populations, we very easily could be tomorrow, right? So one of the things that I work on with my organization is really promoting this combined self-efficacy, collective action, and really fostering compassion, if that makes sense. All right. Now I will leave it open for any questions. Thank you.
Thank you for that wonderful presentation. We actually have a question from the chat from GJ. And the question is, how much is emergency preparedness tied up with affordable housing? And secondary to that, how do we consider and include those vulnerable folks who recently moved and don't know the emergency accessibility in their new location?
That's an excellent question. So I think that affordable housing is a big, big part of it. One of the things that is often focused on is this weather component, right? Because you don't have shelter from the elements necessarily if you're unhoused, and that's really, really important. So how can we make sure that people have a safe place to go especially in the event of adverse weather, whether that be freezing, whether that be fires, hurricanes, things like that. In terms of getting people familiarized with emergencies that are new to their area. So say, I guess I'll use a really recent example. There was an earthquake that hit the Northeast yesterday. That's not something that people in the Northeast are really well versed in. It's not super, super common, especially not the magnitude of earthquake that was hit. I can tell you, like, if I had been up there, I wouldn't have known. Like, one of the things that I just learned is you're supposed to go stand in a doorway or exit the building. One of the things that we can do is start with what seems sort of not intuitive, but is really important, is who is providing the housing? Is it the realtor? Is it the landlord, which is a whole nother issue for affordable housing, but because they exist, the landlord. Whoever is that first point of contact for the person who is moving should ideally be able to provide them with some sort of understanding of what is available. So for example, say you're not from an area with tornadoes and you move to somewhere that does have tornadoes. A good example would be even moving from Florida to the Midwest. If you're from Florida, you're not going to have a basement because you're at sea level. Well, if there is a tornado, typically the safest place to go would be to your basement. So an easy thing would be to point out, we have a basement. This is what your basement is used for. This is where you go in the event that you hear a tornado siren. And also cluing people into little things like, there's going to be a tornado siren that goes off. If you hear that weird noise, go to your shelter place. Also being able to inform people, especially if you are someone like a landlord, because you do take some sort of responsibility for people in that situation, explaining to them what the shelter points are. So say you are running a very large apartment complex, making sure that when residents move in, they have some sort of sheet of paper saying, in the event of an emergency, this is your evacuation route. This is what we will do if something happens. And really just explaining all of the possible scenarios and things that would happen. So I would really say first line, whoever is introducing that person to their new home would ideally be also introducing them to the potential problems that they might face. Now, that's not something that tends to happen. So how do we make that happen? That would probably be something that departments of public health could help with. And I know that there are some campaigns to do stuff like that.
Thank you for that. We have two more questions. One is, what is the disaster preparedness relationship with first responders, especially law enforcement? And how do we accommodate folks who are uncomfortable around law enforcement?
Excellent question. So law enforcement is, at least in the United States, critical to emergency management. In a lot of areas, they are the only people dealing with emergency management. So sometimes, especially if you're like in a small rural area, your police force and your fire department, whether that be an official fire department or volunteer fire department, those are going to be the first people to go help. And if you need more help, they're probably going to be coming from someplace else. Some of the ways that at least police departments have been trying to handle discomfort with their actions, I guess for lack of a better phrasing, is first acknowledging that there are problems, acknowledging these are things that people are scared of and that they have historical reasons to be scared. And that's really, really important because if you make changes without ever acknowledging that there was a problem, people are going to tend to be skeptical. Um, the other thing is having police and fire departments get out and interact with the community in situations that are not related to emergencies. So one of the things that a lot of departments do is they, they go to schools, not as in like there's a school resource officer that's there and potentially going to arrest you as a child, but actually like going and speaking about what they do to students in a really relaxed capacity, letting young people especially examine the equipment in a safe way. Like one of the things my local department does is, they bring the cars, they leave them open, and they're like, look, if you want to sit and see what it's like to be a police officer, let's do it. And really finding ways to connect with the community. Another thing that a lot of departments are doing is getting on social media, and they're trying to exercise their sense of humor. This sort of livens up the relationship a little bit. And it seems silly, yes, but stuff like that can go a really, really long way. It can make them seem more human when sometimes they just seem like this big, scary authority figure. Yeah, so I think that those are the big ones, is really just getting involved in the community and acknowledging that there are problems that we need to be working on.
For sure. It is very valuable. And I think a lot of members of certain professions that have kind of ruined their trust with communities are missing that part of acknowledgement of why the community does not trust you anymore, prior to trying to rebuild. Because oftentimes we see with like physicians, officers, etc., that they just go straight to the trying to develop a new relationship thing, and then they get confused on why there's a lot of pushback. And they're like, what do you mean? I posted a funny TikTok. How do you not like me? And it's like you didn't acknowledge the fact that like I'm scared of you because of XYZ. Um, but the next question that we have is, where can we find recommendations and information to advocate for better inclusion in emergency preparedness strategies, whether that's advocating collectively or individually?
That's a good question. Um, so as far as resources, um, I would look to nonprofits that are not affiliated with the government. Um, so using the pandemic as an example, there have been a lot of grassroots organizations that have popped up to advocate for disabled people during the pandemic. Um, One of the big ones is Long COVID Action. Another one is World Health Network, who I work with. So looking at people who don't have a vested interest in what is going on with the government and aren't necessarily looking to increase their profits or anything like that. They tend to have really good resources that are a lot less biased than what you're going to find through the government. They're not adhering to any sort of agenda. And also, a lot of times they're made by volunteers who tend to be regular people going through the same experiences as, you and I would be going through. So I think that that can be really, really helpful. As far as actually advocating, I'm a big proponent of reaching out to your local Department of Public Health and also reaching out to your representatives, especially your state and local representatives. So not people who are away most of the time in Washington, D.C., but like your mayor, your county commissioner, people like that. Um, And also attending any sort of open, like board meetings or things like that for your county, for your city. A lot of times these things are open to the public. They welcome your feedback. A lot of times they'll have a way that you can submit feedback either online or in writing before or after these events. Sometimes they'll let you apply to speak up. So like school board meetings are a really good example of something that's usually pretty open and allowing for the community to get input. So I think just remembering, like, a lot of times we see the national government and even like people who are representing our states that are away working for the federal government. And it seems like they have a lot of power, but they also, in a sense, don't have a ton of power. And the way that you're going to make the biggest impact is by interacting with city and county local officials. And they're also going to be pretty responsive. And you might find that they actually have a lot of the same ideas and goals as you do. A lot of them have, their kids are in public school. Their kids may go to school with your kids, and things like that.
That's the last question that we have in the chat right now. If anyone else has any other questions, please drop them in the chat now or raise your hand to potentially ask them verbally.
Well, I'll go ahead and I'll also put my um, my email contact in the chat. If you have any questions afterwards or you ever need anything, please feel free to just email me. I'm around and I'm happy to help. Seriously.
Thank you so much for that. I know that from being here at the University of North Texas Health Science Center for so long, I think that a lot of our students could benefit greatly from some of the information that you provided today and a lot of your research interests, especially intertwined throughout our curriculum in education. And so I appreciate you taking time out of your day to come and speak with us and share some of this very necessary and beneficial information with our students.
Thanks for having me. I was happy to come.
I see that someone has unmuted. Did you want to ask a question or are you just unmuted? Abdullah Mohammed. Okay, that's fine. It looks like we were able to end a little bit early. So y'all are able to have some of that time back to spend it how you'd like for this lovely Saturday. Thank you again to you, Dr. Rosen, for coming and speaking with us, and then to those who attended for coming to learn about an aspect that we are not, admittedly, not trained enough in our various disciplines. Have a wonderful rest of your day, and thank you for celebrating Public Health Week with us at the School of Public Health. Thank you.